today's CME on CA Cervix Prevent the Preventable. As we all know that cervical cancer is the second most common cancer in the Indian women. Majority presents in locally advanced stage. Implementing standard care of treatment possess unique challenges. So we have esteemed speakers with us today to throw light on various aspects of diagnosis, treatment and prevention of cervical cancer. For this CME, I request Chairperson Dr. Chindore Madam and Dr. Lokhande to please take their seats.
Good evening all. Dr. Lalita Shindore Madam is a senior OBGYN practicing since 35 years, director at Sri Balaji Hospital since 1988. She is working at ESS Hospital since 2003. She is a very active member in our society and past president of Solapur Society. Next chairperson is Dr. Anna Sai Mokhate, incoming president for IIT this year, and is consultant pediatrician at Navjivan Baal Director of Stepping Stone Child Care Private Limited, Executive Member of Solapur Academy of Pediatrics, Joint Organizing Secretary at Mahapedicon 2015, Honorary Consultant Pediatrician at Police Supra Director Hospital Solapur and Kendriya Vidyalaya School, District Trainer of Neonatal Resuscitation and Nutrition. Won the first prize for case presentation in Mahapedicon 2015. He trained in various pediatric clinical modules of IP. Over to you, Chairperson. You can start the session.
Dr. Amrita Sekhar is talking on widening horizons of department. Qualification, she is a gold medalist. Qualification MRCO, GMS, DNP, FCPS, DGO, PGD, and diploma in gynec endoscopy. She is practicing as a consultant obstetrician and gynecologist at Kutekan Multi-Speciality Hospital since last 15 years. She is having very good academic achievements. She has passed MRCOT Part 3 examinations in December 2018 in first attempt. MS from KU Hospital, Mumbai, and with second rank in Mumbai University. Gold medal in FCPS exam. Assistant professor at KU Hospital, Mumbai for 2 years. Co-authored articles in national journals. Worked as a clinical secretary of Solapur Obstetric Society in 2020 and 21. Now she is talking on widening horizons in PV vaccine.
Thank you, Madam, for kind introduction. Very good evening to all the seniors and colleagues. President and Secretary of Solapur OBGYN Society for giving me this opportunity. Indeed, cervical cancer is a dreaded disease, but the good news is it is truly preventable. Since January, the month for cervical cancer awareness is just approaching. I think this would be the right time to discuss about cervical cancer prevention and HPV vaccine. Worldwide, cervical cancer is the fourth most common cancer among women globally after breast, colorectal and lung cancers. Till now, it used to be the first common cancer among women in India, but now it is the second most common, the first being breast cancer. Number of new cases and deaths are more common in low and middle income group countries. India carries 1/5 of the total global burden of cervical cancer, among which 3/4 of the cases are diagnosed at an advanced stage with poor prospects of survival. So cervical cancer is preventable, and the three main reasons being Cervical cancer has got a prolonged precancerous stage where one can intervene and treat. Secondly, effective screening strategies are available. And thirdly, safe and effective vaccine is also available. Screening is mainly done by pap smear, as we all know, visual inspection by acetic acid, and HPV DNA test. Pap smear has been successfully incorporated in national screening program in developed countries. If a pap smear is done regularly every 3 years, it should reduce the incidence of cervical cancer by 93%. So cervical cancer has already ceased to be a problem in Western and developed countries due to robust screening programs and now also vaccination program. But in India, due to lack of public awareness and logistic difficulties, the uptake of screening, that is pap smear, is only 30%. If you look at the statistics, globally there are 6 lakh new cases of cervical cancer annually, of which 1/5 are from India. Annually, there are 77,000 deaths due to cervical cancer, and this number really exceeds the number of maternal mortality. So, this reminds us of the famous statement made by Dr. C.N. Purandare, FIGO president, in 2018, that too often women are now being saved by the reduction in maternal mortality, but are dying instead from cervical cancer, which is a preventable disease. So this shows us the magnitude of the problem and the total burden of cases and deaths which India bears. It was Harald zur Hosten from Germany who postulated the positive relationship between HPV and cervical cancer in 2005. Now the causal association of HPV and cervical cancer is well established. And he won Nobel Prize for this in medicine in 2008. This major discovery had very shortly led to foundation of prophylactic HPV vaccine and HPV DNA test. HPV, or the human papilloma virus, is the most common sexually transmitted infection. It is transmitted even by skin-to-skin contact through asymptomatic individuals. It is so common that most sexually active men and women are exposed to the virus at some point during their lifetime. And there's increased risk of HPV at younger age. Highest prevalence of HPV occurs among adolescents and young adults between the age of 15 to 25 years. But actually, 90% of the individuals who are infected with HPV will eradicate the virus in 1 or 2 years, and in only 10% it becomes persistent and causes either warts, precancerous lesions, or invasive cancer. More than 200 types of human papilloma virus have been identified. Around 30 to 40 of them got genital HPV infections, and HPV can cause, apart from cervical cancer, HPV can cause several other types of cancers such as oral, penile, vaginal, vulvar, and anal cancers. HPV is basically a DNA virus. It encodes proteins that promote cell growth. The way by which HPV acts is firstly the lytic replication cycle, and secondly, it can oncogenically transform a non-pervasive cell. It affects the basal layer of the squamous epithelial cells, mucous membrane of the oral cavity, vagina, rectum. It is said that HPV infection is necessary but not sufficient to cause cervical cancer. So, this is a diagrammatic representation of how HPV infects the cells and causes multiplication and proliferation. There is local immunosuppression, but there is no viremia in HPV infection. So this is how cells are transformed into precancerous and malignant cells. HPV types are classified on the basis of potential to cause cancer. At least 30 HPV types target genital mucosa and they are classified as high risk and low risk types. The high risk types being the oncogenic types. So there are different numbers. So among high risk types, 16 and 18 are the most common, and among low risk types, 6 and 11 are the most common, which were genital warts. So here we again see that 6 and 11 are responsible for genital warts, and 16 and 18 and many other are responsible for malignant lesions. It is important to note that globally, types 16 and 18 together account for around 70% of the cervical cancers, whereas in India, they account for almost 85% of the cervical cancer. 90% of the genital warts are caused by 6 and 11. The strategies for prevention of cervical cancer are mainly education and awareness, screening and vaccination. WHO has set a global strategy to eliminate cervical cancer by 2030, of which there are 3 important pillars. The first is to achieve 90% vaccination rate for girls below age 15 years. Second is to achieve 70% screening by HPV DNA between the ages of 35 and 45 years. And the third is 90% of women identified with cervical disease should get treatment. So to eliminate cervical cancer, all countries must reach and maintain an incidence rate of below 4 per 1 lakh women, and it is currently 18 per 1 lakh women in India. So we have a long way to meet WHO 2030 elimination target. Currently in India, less than 1% of the girls are vaccinated with HPV vaccine, the target being 90%, and less than 2% of the women are ever screened by high performance DNA based HPV test, whereas the target is 70%. So this figure shows us the dismal statistics as far as the cervical cancer incidence, mortality and availability of vaccine is concerned. So in the first figure, India is showing the dark color that it has the highest incidence of cervical cancer incidence and mortality. But here in contrast, the availability of vaccine and acceptability of vaccine is very poor. HPV vaccine is developed from purified virus-like particles. So HPV vaccination does not cause any infection. HPV vaccine is to be given intramuscularly in deltoid region. No major side effects have been observed so far, and safety of vaccination has been proven for over 15 years. Minor side effects can occur like local pain, induration and giddiness. To avoid fainting after vaccination, patients should be advised to lie down or be seated for at least 15 minutes after the injection. So these are the different vaccines which are available in India, among which Cervix from GlaxoSmithKline is a bivalent vaccine, and Gardasil 4 and Gardasil 9 from Merck are quadrivalent and monovalent respectively. And recently, Serum Institute has launched the Cervavac vaccine, which is also quadrivalent. And these are the dosage schedules of the vaccination. Generally, 0 to 6 is the dosage schedule followed for all the vaccines. And in younger girls, we can even give 2 doses. HPV vaccination is the best defense in preventing HPV-related cancer. In 125 countries, HPV vaccine is already included in the National Immunization Program for girls, and in 47 countries, they are extending this program even to boys, that is gender-neutral vaccination. Australia has already incorporated HPV vaccine in their National Immunization Program as early as in 2007. We also have data from Sweden where cervical cancer vaccination was included in school immunization program for adolescent girls, and it has shown 80% of uptake rate and 88% reduction in the incidence of cervical cancer. Data from UK are also promising. Vaccinating girls below 15 years of age has shown 96 to 97% reduction in the incidence of cervical cancer. And most recent study from Karolinska Institute published in November 2023 stated that most effective way to prevent cervical cancer is to give HPV vaccine to both boys and girls, that is gender neutral vaccination. So by doing this, we may induce herd immunity, which will help to eradicate the oncogenic virus types more quickly. So this is a rosy picture from the developed world, and this amounts to only 1/3 of the world's population. But introduction of a vaccine in low middle income group countries, where 90% of the cervical cancer deaths occur, still remains slow. Now, licensing Indian HPV vaccine at affordable price is a major breakthrough and a moment of great joy. It can truly be a game changer in reducing India's cervical cancer burden. It is definitely more affordable and accessible. Operational guidelines are now being developed for introduction of HPV vaccine in 3 phases in the National Immunization Program to all girls between age of 9 and 14. Very recently now, the trend is shifting towards fewer doses. So we all started with 3 doses of HPV vaccine, but Indian trials have shown that 2 doses are also as effective as 3 doses. So this has led to change in WHO recommendations in December 2022, and even data is likely to come regarding safety and efficacy of single dose of HPV vaccine in coming 2 to 3 years. In India, the concept of vaccination is very well taken. We do have effective measures in place for storage, transportation, cold chain, and administration of vaccine. We have already demonstrated impressive track record in childhood immunization program and COVID-19 vaccination program. So inclusion of HPV vaccine in national immunization program will undoubtedly boost the fight against cervical cancer. If we see data from Sikkim and Punjab, where cervical cancer vaccination already rolled out in immunization program by the state government, they have shown 95 to 97% uptake rate of this vaccine. So creating awareness, removing myths and misconceptions is required to increase public acceptance of this vaccine. For elimination of cervical cancer, improvement in screening, diagnosis and treatment are urgently needed, but widespread vaccination against HPV will have the largest effect. Cervical cancer is one cancer which we can actually eliminate, and it is the time to do so. The main strategies for prevention of cervical cancer are primary prevention by vaccinating adolescent girls, and secondary prevention by doing HPV DNA-based test at least twice from age 35 to 45. So finally, I would like to say that in India, cervical cancer should become a rare disease and not a major public health problem. Thank you.
Hello.
Thank you, Amrita. She has very nicely elaborated about HPV vaccine, and we have to know that it should be given to both female and male. That is very important to form a herd immunity. So next speaker will be.
So for next speech, I invite Dr. Lavini Deshpande madam, a well-known practitioner from Solapur city. She is a consultant obstetrician and gynecologist in Solapur for last 28 years. Contributed in chapter on Dublin. It was my short attempt, but madam has told me that you have to stop now. I will skip. Now she is going to speak on screening methodology for CA cervix and diagnostic importance of colposcopy in HPV disease. Over to you, madam.
Thank you, Dr. Lokhande. Sorry about that. Respected chairpersons, our president, Dr. Vicker, and the entire SOGS team, I am very grateful to you for giving me an opportunity to be with you this evening. Amruta has already opened up this topic very well, and she has taken you through all the statistics and how we have to make our march toward the screening of this deadly disease, that is the cervical cancer. Actually, we don't stop at giving HPV vaccination, and the screening continues. I have dedicated this talk to all those women who have suffered and will suffer from this dreadful disease of carcinoma of the cervix. We have already gone through the statistics. Now I want to take you through the main important thing is the why women die still of this cervical cancer and how can we prevent. And each one of us will be contributing a lot if we do a proper screening for these women who are coming to our OPDs. And that's the opportunistic screening that we have to throw the light on. I must mention these three personalities. One is George Papanicolaou, who actually saw the malignant cells in the vaginal pool of the cells, and he actually introduced this test of pap smear for the early detection of the cancer. In 1960s, my father, my teacher, Dr. B.B. Kulkarni, he came to Solapur and he established the first cytology lab in the Lakidi hospital. And I really, I'm really impressed by his, way of, or maybe the vision that he had, to prevent this cervical cancer. And now, as Amruta has said, we are the Harold Huston. He is the one who actually invented this HPV virus. And today here we are, we know the cause and we want to identify this virus in the cervical cells so that we can pinpoint these cases and we can sort them out from the general population and do the primary prevention by doing a primary screening by HPV DNA. That's very, very important. Dr. Amruta has already impressed upon our mind that what we have to conquer is this HPV 16 and 18. These are the two notorious HPV viruses. And of course, HPV 6 and 11, these are the ward viruses. But we are concerned about all these high-risk viruses. And how can we know who is infected with this? Because rarely any woman gets any symptoms of these precancerous lesions. And that is why we have to do the screening. She has already taken us through what is the pathology, how this virus replicates. But what I want to impress upon your mind is we have got a long gap, like from infection to getting affected. So this is the window that we get for our opportunity to screen these women in precancerous lesions. And that is what we should be, doing the proper screening. Cervical cancer is mainly caused with the persistent infection of HPV virus. All women are vulnerable to get the HPV infection, especially in young women. But those who have persistent infection will progress into precancerous lesions and later on into small portion into cervical cancer. So, where do we actually start? This development of the cervical cancer from 1 year to 20 years down the lane. So, usually it's the age 40 to 50 that we have to catch very well. But when do we start screening? If you take the age below 30 years, even if you are infected with HPV virus, your immunity is at its greatest and it is going to throw this virus out from your body and you are going to win. But If it stays in your body and becomes persistent, and if it is of virulent like high risk virus 16-18, then very small percentage of that can have some cellular changes and then result into cervical cancer. So I would urge that if you have to have a global strategy of screening, what should you be doing? At least do screening for all women at least twice in their lifetime and choose the best method that you can give them. Catch them with HPV screening, primary prevention, primary screening. Or previously we used to do the cervical cytology, that was a traditional. But again, how many cervical cytology or cytopathologists are there in our country? Very few. And that is why we have not really conquered this disease at yet. But today, the technology has changed and we also have to change to this screening methodology. So always there it is in your mind. Which method will I use? How reliable it is? And is it accessible to me? Is it cost effective? How often do I need to do? How long to do? And what happens when I get a positive result? So, to throw all these questions, let's go through it one by one. What WHO says? It recommends that starting regular cervical screening from age 30 onwards among the general population. But if the woman is HIV positive, then it may start earlier, like at 25 years. Women should be screened for cervical cancer every 5 to 10 years, starting from age 30. Suppose today I do a HPV screening as a primary then I can wait to around 5 to 10 years. But if I do cervical cytology, I may have to repeat it every 3 years. And is your patient going to come? So you give her a best chance. So the global strategy encourages minimum 2 lifetime screens with high performance HPV tests by age 35 and again at 45. And that's it. It's not going to cost more than 3,000 rupees for her. But you have to convince her and you have to also change your mindset. So how do you take the sample? It's very simple. As the cervix is accessible, what you need to have is a good light, good speculum, which is a bivalve speculum, which will expose the cervix well. You have to counsel the patient. Take a good smear or take a spatula if you want to do a traditional cervical smear. And immediately you have to spread it on a glass slide and put it in a jar of alcohol. Or you have to have an alcohol spray. If it is not available, you can even send a dry smear. In JJ hospital, they have conducted a big study on dry smear. Even that is okay. But you have to do this. Or for HPV vaccine, you get a brush, you get a kit, you take a smear from the little bit of endocervix and the ectocervix you have to include and rotate it by 360 degrees 2 times and just put it in that liquid medium. Either you will send it with LBC, that is a liquid-based cytology, combined or with HP for the HPV. Then next level is the visual inspection of the cervix and with the acetic acid. That was done in masses in rural areas where they didn't have a facility for cervical cytology. Because taking a smear, labeling it, sending it through the lab is a very cumbersome in masses. So they used to visualize the cervix. If there is a acetowhite area, stained area, they will just treat it immediately, see and treat. Or triaging it and then treating them. So this is how you can actually make your own algorithms depending on where you are based, what is your mindset of screening, how often your patient is going to come to you. So this was like cervical cancer. Regarding this traditional screening method of cervical cytology, with all due respect, it did reduce the cervical cancer by 5-fold in 50 years. But now we have got a methodology where we can screen them at large and we can send this sample to the remote laboratory in a very safe way and get its report in about a week's time. So the turnaround time for HPV screening is around 7 days. So this approach of screening has not been very successful in low and middle income group of women. Another thing is this cytology, when the smear is taken, sometimes it can be inadequate. And sometimes it can be blood stain. In perimenopausal women, you can have a dry smear where it will be reported as an inadequate smear. So what you have is a better thing is a NBC, that is liquid-based cytology, where you take cells from the cervix and put it in a liquid medium and send it through, and it can be processed either only for LBC, the cell cytological evaluation, or along with HPV screening. So these newer tests have been introduced for last only 15 years, and we have been doing that. This HPV DNA is in vogue for last 10 years. We started doing HPV screening test since 2014, and till today we have done about 1,300 tests. And it really gives a very good assurance to women, those who are negative, those who are positive. I'll come to that. There are certain other molecular tests as well, but we are not having access to them as of now. So what is a good practice statement by WHO? That we have to do the primary screening with HPV DNA. That's the WHO recommends. And if you do not have a facility, then you can go either for VIA or you can go for cervical cytology and repeat as I have already told. So this strategy can be like collection of sample. When it comes to that, it can be done by health provider or it can be a self-collected sample as well. That is what is another thing which is included. That women, those who cannot come, they can just access the kit online. They can take their own sample and send it to lab. Those who do not wish to go to the hospital. So this existing program with the quality assurance, like the cytology, they should be continued in those places where HPV DNA is not available or not operational. This is applicable in some of the remote areas. So there are different approaches which are or algorithms that you can follow regarding the screening. One is a screen and treat approach using HPV DNA detection as a primary screening test, and WHO suggests that treating women who test positive for HPV DNA among general population of women. Now coming to this the result of this HPV DNA, nowadays with IUGEN in Pune, this lab actually used to process this with the hybridization technique last 10 years. But now recently they have got what is called as a COBAS machine, COBAS 4800, where they can do a genotyping of these viruses. Previously we used to get the result as positive or negative. But positive means you can have any other viruses which are of low potential and not causing the disease. So you would know whether it is really an alarm for you or whether you need to wait and do some other test for it. So nowadays they have got this genotyping 16 and 18. So moment the woman is positive, they will tell you whether she is 16, 18 or other viruses. So if she is 16, 18, then you may have to try her for colposcopy, and if possible, if you want to do, you can do a biopsy and treat her accordingly. But if she is negative or maybe other viruses are there, you can call her back after 1 year. You don't have to scare her. These women do not have to undergo hysterectomy straight up. That's one thing that we have to tell them. So the counseling of these women becomes very important when we are doing this test. So already we have seen this. So I was just coming to this reporting. So any kind of reporting for the cytology, for HPV DNA, genotyping, you have to have this information so that you will be able to counsel women very well. What we are following is the Bezena system, where you know whether it is negative or they have atypical cells related to squamous cells or glandular cells, ascus. You know, all these terminologies you have to know. And when do you call this smear as inconclusive? When you do not get a sufficient material from the cervix, then this reading becomes inconclusive. In that case, you have to repeat the smear. And as far as possible, they should be taken, this cervical sample should be taken in post-menstrual phase. There are, as I told already, there are 7 algorithms explained by WHO. So I'll just go through that. One, they are categorized into 2. One is see and treat approaches. Via as a primary screening test in some of the patients, followed by the treatment immediately. Then second is HPV DNA detection, either a self-collected sample or by clinician as a primary screening test and followed immediately by treatment. Then third is the cervical. You may do the cervical cytology if there is a ascus or any LSIL, HSIL, then you may like to do the colposcopy and treat. Fourth category where HPV DNA as a primary screening test followed by HPV 16 and 18. That is what we are doing now as a triage followed by the treatment. And for those who are negative, we are not doing anything. HPV DNA detection in the 5th category as a primary screening test followed by a via and followed by the treatment. Then the 6th one, which we are doing at the moment, is HPV DNA detection as a primary screening test followed by a colposcopy triage and followed by treatment. And the 7th category is HPV DNA detection as a primary screening test followed by cytology triage, means you are doing co-testing followed by colposcopy and the treatment. So whenever you are screening these women, I would urge that each one of you should go through its reporting, take a proper sample, encourage women to have these tests and give them a sufficient idea about the follow-up. Keep a record of these patients, give them a recall if it is required in positive cases and treat them or investigate or try them further with a colposcopy. So learn colposcopy as well and then treat them in a pre-cancerous stage whenever required. So the role of colposcopy will always be there when you are treating such patients, and I'm sure that you will avoid not many hysterectomies and save the uterus because you will have mastered how to treat these patients. So as I told, this is personal data that we have done 1,310 primary screening with HPV, and out of that 40 cases have come positive. But previously we used to do not the COBAS technique because it was not available. It was by hybridization technique. So we don't know whether it was 16 or 18, but we followed them up and they are still under follow-up. We have not done any hysterectomies, but 2 of these patients had already had a lesion on the cervix and they were out of interest. We have taken their smear in 60 and 70 years of age. They were already having a carcinoma. So they were harboring 16 and 18. So when you see an advanced disease, you know that there is 16 and 18 sitting over there. So make sure that now your goal will be to actually 90% of the girls getting them vaccinated with HPV vaccine at the age of 15. But it doesn't mean that you will lose them for the follow-up. You will still continue to screen them. And 70% of the women should be actually screened with high quality tests, and that is what we have to achieve, and that the age group is 35 to 45. So this model will work towards preventing this cancer. All of us being together, I am sure we will do this good teamwork and we can do a difference to women's lives. So HPV infection is a sexually transmitted and is usually acquired within the first few years following the sexual debut. Ideally, therefore, the vaccine should be administered before sexual debut, that is before any risk of exposure to HPV, and that is what we should be aiming. Thank you very much.
Thank you, madam. Thank you for giving a clear-cut idea about the screening and various tests. So, after screening and detecting in the earliest stage, so we will have to treat the patient. So now I request Dr. Vinay Biradar sir to give surgical treatment about the precancerous stage. Madam will introduce.
Hello, madam, what is the name of that laboratory where you are stating this?
Ayurvedic Pune.
I-
And it costs around 1800 rupees. But if we take it in bulk, it will cost 1600
less.
rupees. 1600.
We have to send the sample in the
Yeah, they will give the sample kit.
kit.
Yeah, they will give you a kit in which you have to put the. This thing.
Then,
Yeah, the
we have to
material
take
which you get.
the-
Yeah. And it is so simple to do all these tests. And it is so really assuring to tell people
Yes,
that you are
that is
going
very
to next
important.
5 years.
HPV, DNA and genotyping. It's very important.
Please share the number of the group.
Yes.
Welcome Dr. Vinay Biradar. He is an oncologist from Solapur. He has worked as a senior research fellow in breast services at Tata Memorial Hospital. Also worked as a senior registrar in Department of Surgical Oncology at Tata Memorial Hospital in 2010. He has also worked in many malignant disease treatment centers at FMC Pune. Currently, he is working at Vedanta Hospital, Solapur, also at Cervix Memorial Cancer Hospital, Vashi. Hello. Ashwini Sarkari Rugnalaya Solapur and Sri Siddheshwar Cancer Hospital also. So we welcome you, Dr. Vinay Biradar. He is talking on surgical management of first degree of cervical cancer.
Good evening, everybody. First of all, I'm very grateful to Solapur Obstetric and Gynecology Society and Solapur Academic Pediatrics for giving me this opportunity. After these two very good and great lectures, I think it's a very uphill task for me to match those standards, but still, I will try my best. So, after the prevention, ultimately, even after all this prevention and all, we will have some cases of frank malignancies, and we'll have to treat them. In oncology, it is said that biology is the king, selection is the queen, and technique is the prince. So we cannot control the biology. So what we can have is solution of cases and technique of our surgery. So let's try and let's see what we can do with that. Already they have gone through the epidemiology. It is the second most female malignant tumor, and most of the cases are coming from underdeveloped or developing countries. And it is most commonly diagnosed cancer in 28 countries and leading cause of cancer in 42 countries. And vast majority come from Africa and Eastern Asian countries. So in India, it is still second most common malignancy, second common cause of mortality. But the incidence, as ma'am said, the incidence is steadily decreasing because of better screening, better access to healthcare, and awareness in the society. At present, the incident rate is around 14 per 7 per lakh woman, and the mortality is around 9. So this is the same chart depicting the decreasing incidence right from 1990 to from 1990 to 2019. So the incidence has definitely come down. This is slide from Global 20. Just I want to highlight that the same thing that underdeveloped countries have higher incidence and developed countries have lower incidence. The only thing I want to highlight here is look at the incidence and mortality. They are almost same in underdeveloped countries, but if you look at the developed countries, though the incidence is high, the mortality is low. So what it suggests that they are catching disease at early age, and they have so the prognosis is better, and they are getting better treatment. The problem with our country is the detection is at higher stage. So even though they get a treatment, the overall prognosis becomes worse. Just before going to the treatment, this is just etiology, poor general hygiene, early age of marriage, multiple sexual partners, repeated pregnancies, and long-term contraceptive use of more than 5 years is also implicated into as etiology. Smoking and viral infection, as we have just came across HPV and HIV. So before going to the treatment, we have to go through the staging. Why? Because everything is based on the staging of the disease. The right staging will lead to the right selection of the patient and the right treatment. And why I have got the slide here, because in 2018 there are minor changes to the FIGO staging. If you see the asterisk mark here, these are the changes. Earlier it was less than 4 centimeter and more than 4 centimeter, but now they have divided into less than 2 to 4 and 4 centimeter, because the smaller is the tumor, better is the prognosis. Higher is the tumor, worse is the prognosis. And size wise also, the treatment selection changes, the type of surgery changes. So that is important here. And again, earlier the lymph node staging was not involved, but now it is involved because the lymph node metastasis is the single most prognostic factor, and it gives a poor prognosis. And the one thing they have removed is horizontal dimension of microinvasion. Earlier it was less than 7 mm of horizontal and more than 7 mm, which is no longer considered. And as the disease is still prevalent in underdeveloped countries, the FIGO was always a clinical staging, Cervix. But now pelvic MRI is become a mandatory for initial assessment. Why? Because again for the selection of the cases, and it will give you a good idea about lymph nodes and stromal spread or parametrial spread. The prognostic factors. The maximum tumor size, just we have discussed, like why they have changed this staging from less than 2 to 4 centimeter, because it's a prognostic thing. So cervical extension, extra cervical extension. Uterine corpus involvement is not involved in the staging, but still it gives a poor prognosis. And the second thing is nodal involvement. In nodal involvement, we have to look at what are the total number of nodes, what is the location of node, the size, and if they have done a PET scan, then the metabolic activity. Plus pathological tumor type, including HPV status. When there is a malignancy associated with HPV status, generally it has a better prognosis as compared to non-HPV status. And margin status. Margin status is more important in when the tumor is very small and patient has undergone a local procedure like colonization or loop excision. And presence and absence of lymphovascular space involvement. This is a very important thing, because it will change our selection of treatment. What treatment we can give and whether we can offer a patient particular treatment. So why I am showing this points, because the role of pathologist is very important here. And to have a good pathologist, we have to be really lucky sometimes. So before going to the management, I must admit that I have heavily borrowed from these two papers and this NCCN guideline. This recent update on 2023 from European Society of Gynec-Oncologists, Radiation Oncologists and Pathologists. And another guideline is NCCN from 20. We are still in 2023, but why I don't know why it is showing 2024. On the site also is 2024. So as I just mentioned, the staging is very important, because it is divided into T1 stage 1 or T1 disease, T2 disease and locally advanced disease. So that's why where the pathologist roles and the surgeon roles is very important, so as to rightly stage the patient. And generally T1 disease is a microscopic disease. What ma'am was discussing on colposcopy or pap smear. And generally on colposcopy during biopsy, when we come across a surprise or a malignant disease, then T1 disease, the stage is T1 disease. Generally it is a microscopic disease. So here we can save the uterus, and or we can do a limited surgery. So if the tumor is there is no lymphovascular invasion, and spread is less than 3 millimeter, only colonization is considered a definitive treatment, and if there is a lymphovascular invasion in the biopsy, then sentinel lymph node biopsies can be considered. It is not compulsory, but it can be considered. And colonization with adequate margin is considered as a definitive treatment. But when it is more than 3 millimeters and between 5 millimeters, we have to look for lymphovascular invasion. If it is negative, then still the treatment is the same. And simple hysterectomy can also be considered, but colonization can be done. But when the lymphovascular invasion is positive, then we have to do sentinel lymph node biopsy, because if the nodes are positive on sentinel lymph node biopsy, it upstages the disease and the treatment modality will change. And the point here is about adenocarcinoma. The patient with adenocarcinoma generally have a poor prognosis. That's why they should be offered a simple hysterectomy. The same thing, as a little bit of repetition here, but still, loop or lesser colonization is preferable to cold type colonization who want to preserve their fertility, maybe because of more damage to cervix because of the cold type colonization. I personally don't have any experience with this kind of cases. Depth of invasion, margin status, and reliable assessment of lymphovascular invasion is very, very important. What you see here in the box is first is evidence, what evidence, level of evidence we have, and B is recommendation, grade of recommendation. The 4 is that means there are not much of good evidence available, so they have come up with whatever the evidence we have. From this guideline has come. And the bone specimen should be oriented, when we send to a pathologist, it should be oriented, which side is which, and inferior or so we have to have a method for that orientation. And again, it has to be tailored to individual depending upon the age, desire for fertility preservation, histological type, and presence and absence of lymphovascular invasion. Radical surgery represents an over-treatment with a less than, whenever the stromal invasion is less than 3 millimeter. And as I said before, patients with adenocarcinoma who have completed childbearing should be offered simple hysterectomy. So now this is more important. This is the cases we get more. These are the macroscopic diseases. Generally on routine examination, what we find here, imaging is very important. So as to whether to see whether the lymph nodes are there or not. If on imaging there are lymph nodes, the patient straight away goes for a definitive CT-RT. And in some cases, if they are not confirmatory or borderline on imaging, whether we are not very sure whether they are positive or not, then we can try a laparoscopic lymphadenectomy or sentinel lymph node biopsy and then decide about the management. If the patients are lymph node negative on the MRI, then the patient will go for surgery or the radiation or definitive CT depending upon the patient's age, fitness, and desire. So, what these guidelines are saying that sentinel lymph node biopsies are not mandatory, but they are preferred so as to stage the patient properly and decide the treatment. And here again comes the role of radical surgery. And types of radical surgery, I'll come to that later. What type of surgery we can do. So, and the radicality of surgery depends upon the stage of the patient and stromal invasion, lymph node, positive or not, and size of the tumor. So the radical surgery should be done by gynecological oncologist. Is a preferred treatment modality. From 2018, after the laparoscopy has gone into disrepute for this particular malignancy, laparotomy has become the standard approach for all procedures, and I will discuss that also later. Minimally invasive approach may be considered only in low risk tumors. I think in last 15-20 years, this is the only malignancy in which laparoscopy has given a negative survival. So, lymph node assessment should be always the first step during the surgical management. And minimal access surgery can be done before going for a radical surgery. Sentinel lymphobiopsy I have seen when I was in Tata Memorial Hospital. I have not come across again in the last 7-8 years. And again, it comes to having that infrastructure available here for that procedure to be done. And second thing is with this advent of government schemes and all, that option is actually getting smaller and smaller every day. So, intraoperative assessment of lymph node status by frozen section is recommended. If on frozen, if it is positive, then we'll have to abandon the surgery and send the patient for radiation. On frozen section, if the lymph nodes are negative, then we'll have to do a complete lymph node dissection on both the sides. And sometimes lymph node dissection up to even including para-aortic lymph node dissection up to inferior mesenteric artery is also advised. The type of radical hysterectomy should be based on the presence of prognostic factors like tumor size, stromal invasion, and lymphovascular invasion. There are many types of radical hysterectomies are explained, but from 2008, Morrow classification has come, and that they have got a modification in 2017, which is recommended by both by NCCN also and by European Society of Gynecologists also. So what about ovaries? Ovaries preservation should also be discussed in a reproductive age with squamous carcinoma and HPV associated adenocarcinoma. It is specifically said that it is not recommended for HPV independent adenocarcinomas as they have a poor prognosis. And the important thing is, if you are going to preserve ovaries, then opportunistic bilateral salpingectomy should be done to decrease the risk of malignancy in future. Just a few words about locally advanced disease. Most of them go for chemoradiation. These are tumors which are generally about 4 centimeters or up to 4 centimeters. But sometimes some patients will come for radical surgeries. And again, the principle remains same. We have to decide the lymph node stage. If the lymph nodes are negative, then we go for a radical surgery. If you go by Japanese guidelines, Japanese are a little aggressive. Even they for stage 2A, even for stage 2B also they are doing surgeries. So if you go by Western data, generally for stage 2A, most of the patients will go for chemoradiation. Up to stage 2A, surgery and radiation both have a similar survival, but on pathology, if patient has a poor prognosis, poor prognostic factors like lymph node positivity or parametrial extension or positive margins, the patient will have to go for an additional adjuvant radiation. So that will add to the total morbidity and total treatment length. That's why it is advised to should have a bias towards sending patient for chemo radiation in advanced stages so as to decrease the repetition of treatment. There are two specific situations where sometimes we find decision taking difficult. Like the patients are young, they still want to have their family, and so whether can we do a fertility sparing treatment in case of malignancy? I think we definitely can advise them depending upon there are certain guidelines for that, and it can be done in a smaller tumor and early stage tumor. Advanced definitely we cannot save the uterus, so we can't do it. So the maximum size up to which we can do a fertility sparing treatment is up to 2 centimeters. And again, the caveat remains same that it has to be a lymph node negative disease. So if you are going to offer a fertility sparing treatment, we'll have to do a laparoscopic lymph node dissection or a good imaging, and then offer them a fertility sparing treatment. So depending upon the size, up to less than 2 centimeters, they are suitable candidates. And surgeries what can we do? It again depends on what size of the primary tumor. And I think fertility screening treatment should not be recommended for uncommon and rare histological cervical cancers because we don't know their behavior and we don't have data to support that, like neuroendocrine carcinomas and HPV-independent adenocarcinomas and carcinosarcomas. Again, the size up to 2 cm and negative pelvic lymph node status is precondition for any fertility preserving surgeries. So this is the chart for treatment. Once the lymph nodes are positive, that option is out. If there are lymph node negative, then we again stage the tumor, whether it is T1A or T1B tumor, and depending upon that, we can offer conization or simple trachelectomy or radical trachelectomy with a standard lymph node staging. One paper which said that in more than 300 subsequent pregnancies currently reported, there is a 10% likelihood of second trimester loss, and 72% patients carry their gestation up to 37 weeks and more. And another tricky situation what we have is cervical cancer during pregnancy. Sometimes we come across these cases where the patient is the pregnant lady detected to have a malignancy. So here the treatment is depends upon the maturation up to what is the duration of the pregnancy and whether the lady wants to continue the pregnancy or terminate the pregnancy. If she wants a pregnancy termination, then the pregnancy will be terminated and she will be treated as per the stage of the disease. But if the lady wants to continue the pregnancy, then we'll have to see at what stage a pregnancy is. If she is in second trimester, so we'll have to wait for the fetal maturity to approach. For that, we can give her in second trimester we can give her a chemotherapy. And for every chemotherapy, after every chemotherapy, we'll have to assess the response to the treatment. Targeted therapy cannot be given in a pregnancy. And if the fetal maturity is approaching, then we can wait up to 34 weeks and then deliver the baby and then continue the treatment as per the stage of the disease. And generally, the section has been advised, normal pregnancies are not advised because they have shown to have a poor prognosis after normal delivery. So this is just about, this is the basic what we have seen the guideline, broad guidelines how we treat the patients. So the take-home message would be we have to stage the disease properly. Once we stage the disease, then we can decide the treatment. And with these guidelines, it has to be also personal, depending upon the patient's desire, where the patient is staying, what kind of infrastructure we have, and what kind of logistics we have. Because everybody says we have to give radiation and chemoradiation for everything, but sometimes we have to take into the consideration that radiation treatment is almost 6 weeks, and patient has to stay in the city when they are from periphery. They have to stay in the city for 6 weeks, and also what about the side effects? So it is very personal. So we have to take into all the factors into consideration and take a decision for management. This is just about central lymph node biopsy. It can be done by ICG, indocyanine green or a gamma probe when technetium 99 is used. And once we inject, then we look for where the uptake is, and from there we do a lymph node dissection. So wherever the suspicion lymph node is there, it should be sent for intraoperative assessment. If any lymph node involvement is detected intraoperatively, then further lymph node dissection and hysterectomy should be avoided, and it will be sent for CTRT because the patient immediately becomes locally advanced disease. And if the sentinel lymph node is negative bilateral, then bilateral pelvic lymph node dissection below the iliac bifurcation should be. And the lymph nodes from all traditional area like obturator fossa, external iliac regions, common iliac regions, and perisector regions should be removed. This is the update on Korum-Mauro classification. Why this has come? Because right from Burdens to Mays to Duska, there are so many definitions and classification of radical hysterectomy. So as to streamline and remove the confusion, this classification has come. The difference between all this classification and this classification is Moro classification thinks in terms of a three-dimensional disease. The others were always a lateral extent, basically whether you take parametrium medial to the ureter, at the ureter, or lateral to the ureter. What they are saying is we have to think in a three-dimension, like ventral parametrium, dorsal parametrium, and lateral parametrium. Because why this has come? Because to save the nerves and decrease the morbidity of the surgery, bladder and bowel dysfunction, and this surgery divided into from A to B. So this is a comparison. Between the routine, like this is extrafacial hysterectomy, modified radical hysterectomy, and radical. And what we see type A, B, and C. This is Moro classification. And again, it depends upon where we are cutting the paracervix and whether we are deroofing the ureter, complete deroofing or partial deroofing. That defines the type of surgery. Smaller the tumor, lesser the surgery. Higher the tumor, more extensive the surgery. To just show the what was they are discussing is, these are not my slides. I have borrowed it. This is the ventral parametrium. Ureter here, and this is dorsal parametrium. So this was the concept. We have to dissect here also, laterally also, and posteriorly also, because the nerves they lie along this plane. Splanchnic comes from here, the hypographic plexus and the hypogenic nerves come from here, and they enter here. So, and the second thing is, the second concept was always we were taught that water under the bridge, like the ureter process from below the uterine artery. But this concept is like it's like a fork. The ureter is there above the uterine artery, and below there are veins. It can be deep. The names are different for the veins. It can be deep uterine vein or vaginal vein or vesicle. And there lies the nerves. So we have to dissect those individually, ligate those, and push the tissue downwards or laterally so as to decrease the damage to nerves. That's what they were saying. So these are the nerve, and this is the blue is the vein, red is the artery, and we have to dissect these spaces: paravesical space, paravaginal space, pararectal space, and we have to create those spaces, identify the veins, and ligate the veins rather than bunch ligate. So the risk of injury to the nerves are less, and the morbidity is less. Before concluding my talk, I just said that it's the only malignancy in last 10-15 years where laparoscopy has gone into disrepute. Because this paper came in 2018, and actually everybody was expecting to have all the laparoscopy trials they are done on non-inferiority basis, to prove that they are not inferior to open treatment in terms of survival and overall survival and progression-free survival. But at the end of 3 years, what they found that the cases which are being operated by laparoscopy, they have a poor overall survival and they have higher incidence of intra-abdominal metastasis. And the actual duration of follow-up was, the trial was 4.5 years, but at the 3 years only when they found that there was an increased incidence, so the trial was stopped. And there's a lot of discussion what could be the reason, and so two reasons they thought was uterine manipulation during laparoscopy, and second is CO2 insufficiency. That may be causing the dissemination of the cancer cells into abdomen. And uterine manipulation also causing dissemination of cancer cells. So as of today, the gold standard for surgery would remain as a laparotomy and laparoscopy in very selected cases. There is a large trial going in. The problem with this trial was it was not addressing the robotic surgeries. It was only laparoscopy surgery. So there is a large trial going in Japan now with 800 patients of 800 patients. It is open versus robotic surgery. 2024 it will end, and by the 2028 you will get the results. I think by that time we'll have a definite picture of what can be the mode of surgery. Thank you very much.
Thank you very much, Dr. Viranda. Very nicely explained all the stages and the treatment accordingly. What is take home message is laparoscopy is better than laparoscopy in most of the cases, not all. And PET scan should be done in each and every case suspected, not necessary. But in suspected cases, at least when the lymph nodes are involved, it means
If on MRI there are lymph nodes.
MRI also can
Not for the people.
Okay.
For the next talk, I request Dr. Hemant Sate sir, Senior Pediatrician from Solapur City. He is working in the Solapur City and is consultant pediatrician since last 33 years. He has worked on many posts of IAP, Maharashtra State. He was organizing chairman for Mahapedicon 2015. He also worked on various posts of Maharashtra IAP, and recently he has won badminton matches. He has won singles and runners up in doubles Maha IMA badminton sport contest in Jalgaon in 2020. In 23 IMA National Olympiad badminton 55 plus years plus singles and doubles runners up. And recently he has won the singles and doubles in Maha IIP Sport Meet at Nagpur 2023. Recently he has won. So now I request sir to enlighten on topic of cervical cancer vaccine inside trends in adolescents. Over to Sate sir.
Thank you, chairpersons, for the kind introduction, and thank you, the organizers, for arranging a meet of gynecologists, obstetricians, and pediatricians together, because the topic of vaccination for CSR is a concern of both. So, therefore, I would be talking to you all in the next 30 minutes about the cervical cancer vaccine, and especially everybody wants it in the adolescents. Also, it's in specific. In general, when I usually start with whether do you feel that doing vaccination is the key to vaccine preventable disease? And to all of you, let me ask you a fair and fine question. How many of you are doing vaccine for CSR or cervical cancer vaccine in your routine OPDs? And how you have got any poster projected? Because this is one of the cancer which is very, very preventable, and maybe they are putting it as 2020. Both of us, these branches are together, will be able to do before 2030 also. This is what my prediction is. So I just ask everybody in this way, how many of you have given the cervical cancer vaccine to your own daughters or by yourself also? I am one of them. I am one of the few who has given vaccine to my daughters even before I may thought of giving vaccine in a camp. And I have given 0, 1, 6 months vaccine to my daughter when we right now know that even 0 and 6 months is enough. Then I just put a slide to say. That this is an intramuscular vaccine, and you cannot give it subcutaneously. You cannot give it subcutaneously, neither intravenously. And vaccination of every child maybe you can say to an adolescent, is a responsibility to be shouldered by government agencies, parents after one-to-one discussion with the doctors and the vaccine manufacturers, where the vaccine has to be highly effective, safe, reasonably cheap and thereby cost effective. I am more emphatic, especially in cervical cancer vaccine. And second, you already know, I will come to that a bit later on. And thirdly, I feel parents and so the doctors who choose not to vaccinate, they do it often do so to avoid a risk of vaccine. But I feel choosing not to vaccinate is a riskier choice. Now, the question is, can cancer be prevented by vaccination? Yes. Hepatitis B is the brilliant example, and the next one is the cervical cancer. So this is one of the slides which shows a study in Ahmedabad that if we are women with no history of cervical cancer were screened in the urban slum of Ahmedabad, and one lady out of 3 was testing positive for HPV, and out of that 77% were positive for the higher risk. So just see the burden that we are facing and you are facing, and we are trying to make your job simple by giving vaccination starting at the age of 9 years. Now, how can we prevent cervical cancer by vaccine? Let us go to the pathophysiology and can we create it nearly by vaccination? In females, CIN2 and 2, 3 cervical intravenous neoplasia and adenocarcinoma in situ are taken as immediate precursors of invasive squamous cell carcinoma and adenocarcinoma cervix. Now, in cervical cancer cases, 99.7% presence of oncogenic HPV DNA has been demonstrated, and this we can very well the invasion of the mucosa by HPV. If we tackle them right in the beginning at 9 years with the vaccine, we can prevent it, and that's the magic where we can think of eradicating CS cervix from the country as a whole. Now, what is this HPV? Now, it is a member of papilloma viridae, small non-enveloped DNA virus. Most infections are transient, benign, self-repressing, as already told by previous speakers. But the persistent genital infections, we insist, so also already insisted on that, persistent genital infections with certain viral genotypes can cause the perianal, sorry for that spelling mistake, and the perianal precancerous and cancerous states. So HPV are largely non-lytic and restricted to the epithelium, and the recombinant DNA technology has done the magic. Is used to express the L1 capsid protein of HPV in the yeast, which self-assemble to form empty shells which are resembling a virus, that is called a virus-like particle. Now, what is the beauty of this? It doesn't have any genetic material inside, but has got a potential to produce a stimulate the immune system of an individual to whom you have injected. And these VLPs, the vaccine uses these VLPs as antigens to induce a strong protective immune response, and and secondly, if another exposure occurs, the vaccinated person's antibodies against L1 protein will coat the virus and prevent it from releasing its genetic material. And that's how we can use the cervical cancer vaccine to prevent the carcinoma cervix, or to be very specific, precursors of the CIN2, 3 and AIS. So in a study of my character, 54 to 69% of women were found to be infected with HPV, 6, 16, 18, and infections had the infection actually the specification protection is naturally serotype specific. Now HPV, as previously already told, I need to repeat, over 200 serotypes have been identified. 15 to 20 are high risk carcinogens, and so also there are genetic HPVs which are further classified as high risk, probable high risk, and low risk. When we started using the cervical cancer vaccine, it was even in the world it was not recommended for the males because of the paucity of the quantum of vaccine available and the quantum of females which are at threatened risk of getting a cancer, and which is very different. When now it comes to serum, now I am sure looking at the corona scenario, serum will be able to produce n number of vaccine units, and we will be able to cover even the males. and I'll tell you the statistics about the males also. And therefore now Australia was initially the first country to say that it can be given. Of course, it can be given with one-to-one discussion with the parents regarding whether the male should be given vaccine or not. But then the initial priority was for the females. Then HPV is content as that I already told, and then what happens is now the exposure to HPV at a younger age increases the risk of cervical lesions and cancer in the womb, and therefore pick them as early as possible. And then that is our pediatrician job. We try to give this vaccine right at the completion of 9 years of age, and the risk of invasive cancer will substantially decrease. I'll show you a slide which shows in US how things have happened. The prevalence of HPV after introduction of the vaccine program in US, it just went down by 64%. In the pre-vaccine area, I just showed you the table. And the same is the story when you use a water. Initially, we used to have a bivalent vaccine, mainly made for Cervix, and now we have what is quadrivalent, is also probably generated wards. The quadrivalent HPV vaccination reduced the number of precancerous cervical lesions among women in USA. In the US, the same story has repeated. And then there are a few characteristics of it. I just narrated who are the manufacturers for bivalent, quadrivalent, and nanovalent vaccine. The 9-valent vaccine also is covering many aspects of the male partners. So, into 16 and 18 is covering CSR almost 80-83%. 6 and 11 are covered, but other ones 31, 32, 45, 52, and 58. These are the other serotypes which are covered in the 9-valent vaccine, and we will be able to cover it up to 90%. Now the girls. Now what are the recommendations, especially by WHO? Girls aged 9 to 14 years, 2 doses at least 6 months apart. Interval, and the interval can be extended to 12 to 15 months in circumstances where the second dose is not repeated within 6 months. And the catch-up immunization, 15 years till 26 years of age, 3 doses. However, the second dose should be given after 1 or 2 months, depending upon which vaccine is used, and the third dose after 6 months after the first dose. There are also limits to beyond which you cannot give the second dose. It cannot be calculated as a successful vaccine. So also there is a time bar given where you cannot give any the third dose at any point of time beyond the age of 15 months from the first dose. Now older girls and women who have been sexually active, counseling regarding the reduced efficacy of the HPV vaccine and the importance of screening from the age of 25 years. So vaccination in the childhood coupled with the screening later on beyond the age of 26 years, and plus as we told in the initial speakers, will take our way to the success of eradication of CSMs. Now, safety and adverse events, in general, I have used at least, I must have used more than 100 vaccine units by now. And then in general, it is very well tolerated. In studies in US, pain and swelling at the injection site, and everybody's situation is the same. And in the mild adverse reactions like fever, dizziness, and nausea, fainting, majority times anxiety. But what I do and everybody of us do in our clinics, whenever we give any vaccine, say including MMR vaccine for that matter, we feel like driving, and still it can produce anaphylaxis. We ask the patient to remain in the OPD for next 30 minutes, so that any adverse reaction can be quickly picked up and managed accordingly. Serious adverse events are almost rare, but anaphylaxis, as you know, can always occur as a rare event. And what are the contraindications? The contraindications almost nil except the allergic reactions to any previous dose or a component is in particular of the vaccination. And girls with severe febrile illness, pregnant woman, if pregnancy occurs after initiation of the regimen, it is better that you postpone the next doses. If you want to take vaccine before, it is recommended that you should not have been pregnant till you complete the vaccination doses. As far as lactation is concerned, there is no harm. The vaccine is excreted in the breast milk, so also protects the child. So lactation, no problem in pregnancy, as I have told you. If pregnant, postpone. If you want to take vaccine first, postpone the pregnancy. Then in 2014, US FDA approved another 9-valent HPV vaccine. These targets, in addition, as I have told you, the serotype covers to the tune of 90%. I have written here 9, but this is slide older slide. 9-valent vaccine also is available right now. The other few important points about the vaccine is should not be interchanged among the two available varieties unless you are compelled to do so. The WHO paper says the target population is 9 to 13 years. In simple words, before the first sexual day. A 2-dose schedule with an interval of 6 months between the doses. Right now, so in between 9 to 15 years, this 1 dose or 1 month is not required, and the same efficacy is there in 15 years is there by using 0 and 6 months doses. And max not interval not greater than 12 to 15 months is sufficient. So you cannot, like any other DPT vaccine, you cannot give say suppose we take one vaccine for today, it takes after 4 years, no, not permitted. So beyond 12 to 15 months is not permitted, and 3-dose schedule has to be completed, and the recommendation is like that only 0, 1 and 6 months, 0, 2 and 6 months depending upon which type of vaccine you are doing. And then for giving a vaccination, it is not necessary to screen for HIV or HPV prior before vaccination. Only with HIV, the immune response may be slightly less. Now the duration of protection, I have just tried to put it here, and catch-up vaccination between 30 to 45 if not vaccinated, and ideal time is before, as I have told already, before the sexual activity starts. Then in few special situations where delay is in the 2nd or 3rd dose, there is no need to restart the vaccine. Vaccination period of not more than 15 months is required to complete the vaccination schedule, and if the time period between 2 vaccine doses is less than 5 months, 3rd dose is recommended 6 months after the first dose, but 3 months after the second. So depending, both the criteria have to be fulfilled. So if the dose was taken at 4 months, you have to give it at 7 months. Then co-administration with other vaccines, as you all know, it can be given very well with DPT and other vaccines. There is no interference, immune interference, and only thing is naturally with the separate syringe and at different sites. This is just to reduce the number of visits. Then HPV in men. Now, prevalence of HPV disease in men is benign carcinoma at the tune of 18.7%, scrotal 13.1%, perineal or perineal 7.9%, and any site is 21%. Now, there is an interesting observation. The reduction in the incidence of genital warts is one of the first markers for the effectiveness of HPV vaccine at a population level as they develop over a few months. Whereas precancerous lesions and cancers usually develop over a period of several years. In specific relation with CS service, it is to the tune of 15 to 20 years. So you have got enough of time to intervene and manage these patients successfully towards the end. And what about the victims of sexual abuse? Now, the Advisory Committee on Immunization Practices, ACIP and CDC, suggests that all those who are between the age of 9 to 21 years and 29 to 26 years, 3-dose schedule, first at the time of initial interaction, examination, and 2nd and 3rd dose in the first or 2nd month, and second 6 months after the first, or if the 2nd is delayed, then there has to be a gap of 3 months between the 2nd and the 3rd. The American Academy of Pediatrics begins the schedule for vaccination at the age of 9 years, so also the Indian Academy of Pediatrics. Now, this I already told you what is that human papilloma virus and what we are going to do by using a vaccine and how we are able to cover it to the tune of eradication. Now, how does the HPV spread? This must have been covered, I was a bit late, but it could be used with sexual activity could result in HPV infection and can spread through vaginal, anal, oral, and somebody who has got oral sex with the person who has had the virus. And therefore came the concept of using the vaccine in men also. It is most commonly used spread during vaginal and anal sex. Also spreads to close skin to skin contact during the sex, And a person with HPV can pass the infection to someone even when they have got no signs and symptoms. That already has been told by one of the speakers. And a person, if a person is sexually active, he or she can get HPV even if they are having sex with only one person. And symptoms can be developed years after having sex with someone who has an infection. And this makes it hard to know whether one person is when the person is first getting infected. This slide is a repetition of what Dr. Gupta Madam had told, and therefore I just skip the beauty of or the interesting part of this. The HPV virus doesn't cause cell death, and therefore is not getting exposed to the immune system, and that's why we would like to stimulate the immune system by using a HPL protein which doesn't have any genotype material inside. That I already showed you in another slide, and therefore there is poor exposure to the antigen present in cells, and therefore the infection per se doesn't give you immune protection. And this again a repetition, which I just skip classification. This again a slide which is repetition, and high risk type and low risk type. This is what we are trying to show you. But then there are also other serotypes 31, 33, 45, 52 and 58, which are again involved in the CS service, and they have been covered in the 9-valent vaccine. Again the same repetition. Now this is about the burden of women at risk for cervical cancer beyond or equal to 15 years is 51.15 crores and is 17% of the total globe, and whereas annual number of cervical cancer cases are to the tune of 1.25 lakhs around and contributes about 21% of the globe, and out of which about 60% of the deaths are there every year. Almost this photograph shows every one lady is dying every due to CS cervix every 8 minutes, and this is a very preventable type of disease, and I think together we must do it, and together we can do it, and we will do it. This again maybe a slide which is repeated. So signs and symptoms. I need not tell you same story about the warts. Now, again I have said the cervical cancer can be prevented just not by vaccination, but you have to educate and make people or children aware. So also their parents, as the earlier speakers said, by screening and periodic screening and in the vaccination. Then the cervical cancer screening, I did not go into that, is already a repetition. The same repetition is about Cervavac, which is a 4 quadrivalent vaccine. The younger the better, I have already told you. So same is the repeat slide. And the Serum Institute's goal, if Serum Institute decides to target something, we know nothing is impossible in this world also for the serum. Once they have the virus material for them, and they can do production in infinity, I would say, and actually that is really needed for CS cervix, and I think therefore we should be able to conquer this CS cervix in up to 2030. Which why I am insisting on this is because we are not able to, though we are not eradicate polio from our side since we are using it from 1995 only because our Pakistan and Afghanistan are still by the side and they are living the threat. Whereas using the doses in millions and billions, we will be able to cover CS cervix to a very nicer pattern. Then I just skip these slides because they are already the repetition of the previous speakers. And then the seroconversion, this is one of the interesting slides. The seroconversion at 7 months means 1 month after the completion of the 3 doses of CS Cervix vaccine, Cervavac, the seroconversion is almost 100%. So in all the serotypes, and therefore the protection is going to be very robust. This is a robust immune response and very assuring response, and the geometric mean titer for baselines have not been decided as yet as far as the cervical cancer is concerned. But let me tell you, the GMT levels are 1,000-fold above the levels which are required for a female for CS Cervix. So even if age related we are not able to quote it, 3 doses and lifelong immunity, it is almost very sure that the lady will be having enough immunity to have so that the extreme invasion will absolutely be prevented. So overall summary, Cervavac has demonstrated a robust antibody response. More than 100% conversion was reported in all 4 vaccine serotypes. GMTs are more than 1,000-fold, and adverse events have been reported almost virtually nil, except pain and reddening at the site of infection and the injection. And no vaccine-related adverse reactions or solitary reactogenicity with severity grade 3. Overall incidence of AEs with Cervavac is within acceptable limits, unlike for that any other vaccine. This is something about the product infection prevention I think everybody must be knowing, because serum must be campaigning to a very great extent. We skip that, but so also about a chart will show Gardasil, Cervavax, Gardasil 9 and the original Cervix vaccine. And then these are the partners. Then again, what is the composition? This has been written, is already nothing of much interest to us. And pricing. Serum is known for giving it at almost throwaway price. So that, but I always say to those serum people, they are always late in the market, maybe purposefully or purposefully for somebody, and otherwise they can just switch in the market. And therefore, what I believe is treating to cure is your priority, you all obstetricians and oncosurgeons. Preventing by vaccination is my priority. Now it is up to you to choose. Best way is vaccinate early to prevent and focus on the periodic surveillance and early intervention to give complete cure. I think the decision is yours. Thank you very much for your patience.
Thank you, sir. Thank you. Well played. You have won the singles and doubles also. Thank you, sir. Any questions? I request Madam to continue the session. Thank you.
Thank you. It was a wonderful session. I request the chairperson to felicitate our speakers. Dr. Amruta Bhumtakar. Dr. Rohini Madam. Dr. Vinit Virasar. Dr. Sajid Sir. I request President Dr. Vivkar sir to felicitate our chairpersons.
सर वरती स्टेज थोडं पुढे सर ओके रेडी
On behalf of Sierra District, I would like to thank Solapur Academy of Graphics and Solapur Academy of Technology for giving this fantastic opportunity. This was a real academic feast for cervical cancer management. I would like to thank all speakers for giving this opportunity. So thank you very much. Now Cervavac is available in single dose. Cost is also very economical, and Cervavac is the first gender-neutral vaccine available in the market. You can give this vaccine to boys as well as girls also. So thank you very much.
I request everybody present to come forward for a group photo.
Yes, ready?